Hi, and welcome to the first edition of Rad Exchange. Today we're going to talk a little bit about things that sabotage your image quality. We like to call those scan killers.
When we look at a scan, we always have to do a balancing act between the amount of information we get, which is called diagnostic yield, scan quality, and exposure to the patient. So there's always a give and take here. And I think we need to look at it more as a benefit versus risk ratio. The traditional teaching has always been risk versus benefit, but I think we should look at it as benefit versus risk. So what are some of the parameters that we have to evaluate when we look at scan quality and diagnostic yield? Well, the first and foremost thing we need to look at is the purpose for the scan. Different tasks require different levels of resolution and different field of view. So let's talk about field of view for a second. Field of view is the area of capture in your scan. And if you're interested in looking at 3 teeth, you don't need to get the entire maxilla and mandible to evaluate that area. You want to try and keep it to the particular area that you're interested in. Next, we talk about resolution, and resolution is the ability to see 2 things that are very close together and separate them. We need higher resolution when we're looking at something like a endofill, or looking at pathology, or looking at a margin, looking at lamina dura. But there's a give and take here, because the higher the resolution, the more exposure to the patient. Additionally, the larger the field of view, the more exposure to the patient that we see. Finally, we have to consider inherent image capture artifacts. This is a rotational image, and not every structure in the body is round, and not every structure in the body is a straight line either. So these are some of the issues that we've run into with 2-dimensional imaging, and the same thing holds true for 3-dimensional imaging. So today we're going to focus in on 3 aspects of image quality that we call scan killers here. Number 1 is motion. Number 2, metal or metallic restorations or artifact that we see, and finally talk a little bit about patient positioning. When we talk about cone beam computed tomography, we have to realize that it's a little bit different than conventional computed tomography. In conventional computed tomography, if your patient moves, it just messes up that particular slice in your scan. With cone beam CT, when the patient moves, it impacts every voxel in the scan. So patient stability is extremely important that we have to deal with. Sometimes your patient will be in the exact perfect position and they swallow halfway through the scan, and that impacts image quality. And finally, we have to look at gantry stability. Some patients actually put their weight on the gantry, and it's really not built to stabilize the patient's weight as well as the receptor and the source of radiation. So here's a sagittal view we're looking at, and everything looks pretty good until you look at the uvula base of tongue area. And you'll notice that there's sort of a secondary shadow there. That's a swallow artifact from a patient. Here's a panoramic reconstruction. And at first blush, things look pretty good. But if you take a look here at tooth number 15, for example, you can see that there's a double outline of the coronal aspect of it. And as we move our way towards the anterior, you can see that virtually every tooth in that quadrant is duplicated to a certain extent. And this is fairly typical for a swallowing artifact. If we take a look at our condyles, you can see that the right condyle looks in pretty good shape sagittally, but coronally you can pick up that there is a double outline. And on the left side, the motion artifact or the swallowing artifact is much more manifested in the sagittal view, but you can also see it in the coronal. This is a nice coronal view, and you can see that every structure is duplicated. And when every structure is duplicated, that's patient motion rather than a swallow. So here's an axial view. This has it all going on. There's motion, the machine's not calibrated, and I think you can certainly appreciate that there's much more noise than signal in this particular view. And the whole purpose is to localize an impacted canine. And this requires a fairly high level of resolution, because we're interested not only in the position of the canine, but its relationship to cortical bone. And also, usually we're worried about the root of the lateral incisor that's next to the canine. So we have a sagittal view and a coronal view of the same patient. And I think you can appreciate that there's an awful lot of noise in this image. We see some cortical duplication, which is indicative of motion. And this is a sagittal view looking at the canine, and when you start to count teeth, you might be up to about 12 in this view. And we know that there sure aren't 12 teeth in that area. So we see that cortical repeat because of motion. Okay, metallic artifacts, important to talk about, because not just computed tomography, not just cone beam computed tomography, but even panoramic imaging, anything that's rotational will give you metallic streaking. And these streaks all go in a horizontal orientation. So metallic restorations first and foremost. You can't do anything about that because the patient has them in their teeth, and not too many patients would let you take those out so you get a prettier scan. But the more metal the patient has in the mouth, the more streaking that you'll see. The implants do the same thing. And because it's a fairly large hunk of metal, you'll start to see a radiolucency that surrounds most implants. And that's referred to as a beam hardening artifact. We can also see some of these changes in root canal fills, especially if the tooth has a post placed in it, orthodontic brackets. The single bracket is not very radiodense. The multiplicity of brackets tends to add up to create more scatter in your scan. And then finally, earrings and facial jewelry. So here's a panoramic reconstruction from cone beam CT. I think you can appreciate the horizontal streaking that we see here. And also there's motion. If you look again at the maxillary second molar, you can see a double outline. Same with the mandibular second molar there. The horizontal streaking we see is all from the metallic artifacts, all from the metal. This is just a close-up of the same area, and I think you can appreciate that we have quite a bit of noise in that image. Here we see some implants, and generally implants are the biggest piece of metal that we'll see in a particular area. And by and large, they all have this little ring around them. You can see with the arrow that's beam hardening artifact. And it's really hard to delineate beam hardening artifact from legitimate bone loss around an implant. I will usually take a look from the axial view and work my way down and take a look at whether there's symmetry in that radiolucency around the implant or not. Generally, your pathology is asymmetric around an implant, whereas the beam hardening artifact is a little bit more symmetric. Here's an endo or root canal tooth that you can see has a rather large fill in it and a little apical fill as well. And not only do we see scatter from the entire fill, but especially the apical. You notice that streaking here. And where it streaks as a radiopacity, it also streaks as a radiolucency in the next view to the right. Axial view right here, taking a look at several root canal teeth in the mandibular right posterior sexton, and considerable scatter from the metal there. This is a coronal view where we have a heavily restored dentition plus root canal fills. The more metal you have, the more streaking you're going to see. Again, a view, we've got root canal fill in the maxillary view. In the mandibular fill, you see root canal fill and also a marker for an implant site. This is an axial view looking at orthodontic brackets and the amount of scatter that comes off of them. And notice again, one by itself won't produce that much scatter, but if you have a series of them, and in this case, they're on virtually every tooth in the maxilla, you can see there's rather significant scatter that comes from those brackets. Again, another view of the orthodontic brackets plus a nose ring. Notice the horizontal streaking all the way through the scan, through the soft tissue from those brackets. With panoramic imaging, we always stress removing earrings before you take the image, and the same holds true for cone beam CT. Here's a view, we're looking coronally, and you can see that there are two rather large earrings that are present there, and the streak goes all the way through the scan. In this, especially noticeable in this panoramic reconstruction. And finally, here's scatter from an implant marker, and it's just a small aluminum tube. Next, let's talk a little bit about patient positioning. Again, we want to talk about the area that we want to see, or the field of view, the occlusal stability of the patient that's usually controlled by a chin rest, whether a bite stick is present, whether the patient's wearing an implant stent or a splint, spinal column position, and finally tongue position. When we talk field of view, We're interested in putting the area of interest in the center of the scan. And we want to try and do that horizontally. Not every machine will give you the ability to center both horizontally and vertically when you have a particular area that you want to see. One of the reasons that we want to try and get the area of interest in the center of the scan horizontally is that the top and bottom, or the vertical aspects of the scan, tend to have diminished image quality in that area. We definitely don't want to use one size field of view for every situation. If you're looking at an accessory canal and a root canal tooth, you don't want to use the same scan that you would use for a beginning orthodontic case evaluation. So let's look at some of these positioning components and their impact on diagnostic quality. So let's start with the bite stick. We have a bite stick in place. This usually pulls the anterior teeth end to end. When you pull anterior teeth end to end, especially in a patient who's either class 1 or class 2 skeletal, you're going to find that that opens up the AP airway dimension. It also pulls the condyles forward, so the condyle-fossa relationship is not necessarily accurate. And if we're going to separate the anterior teeth, most likely we are going to separate the posterior teeth as well, and that's your occlusal relationship. So bite stick gives an example of impact on all three of those areas. If the patient is wearing a splint or a stent, the same thing holds true. You're going to open up the bite, which will change occlusal relationship, potentially the condyle-fossa relationship, and the AP airway dimension. When the spine is twisted, and this happens when the patient, a lot of times when the patient is larger than your average patient, you'll have an asymmetric narrowing of the airway space. And an asymmetric airway space narrowing is a red flag for the interpretive radiologist, because it usually means there's a space occupying lesion. And we certainly don't want to alarm a patient because of a positioning error. Tongue position, wherever the tongue goes, so goes the AP airway dimension. And then finally, we'll talk about the chin rest. The chin rest is essential for stabilizing the patient's head as long as we don't use it excessively. And sometimes you'll see a scan where the posterior teeth are discluded because the chin rest is placed too tightly. But by and large, we want to try and maintain the normal occlusion, and the chin rest helps hold the head in position. So let's take a look at some examples here. This is obviously not how you want to position your patient. This is just a raw scan right here with the chin way up and the head is twisted. And if you take a look at the inferior aspect on the patient's left, you can actually see a carotid atheroma in there. Okay, so here's an example, a sagittal view. We have a couple of things going on here. First, here is the chin rest. And if you'll notice, the anterior teeth are separated. So you're going to have to take a look at the posterior teeth to see if they are separated as well. Additionally, the tongue is retruded in the scan. And when the tongue is retruded, the tongue drops back and also changes the AP dimension of your airway. Again, if the chin is too far back, you'll also notice that the condyles are placed posteriorly in the fossa. And what we'd like to see is the condyle centered in the fossa. And this is obviously not the case here. Now, if this were a true anatomic relationship, we would think that this is a risk factor for anterior disc displacement rather than a positioning error. Okay, so we can take a look here. Notice there's rather significant anterior overjet. The soft tissues of the chin are not compressed very much, but we have a little bit of swallow artifact right here. And again, that will impact how we evaluate the airway. Having something in between the teeth, and in this case, I believe it was a large piece of wax. You can see that the teeth are separated all the way through the dentition, and note what's happened to the condyles. The condyles are sitting roughly 3/4 the height of the eminence, which is not your normal relationship at all. So if the mandible gets pushed forward that far, it also is going to open up your AP airway dimension. Here's a sagittal view of a young child. I think you can appreciate that there is significant space between the anterior aspect of the chin and the chin rest, so don't have an expectation that that's going to impact the occlusion on your patient. But also notice that the tongue is retruded in the scan. The green line here indicates the true AP orientation of the cervical spine. And if you take a look at this patient's mandible and maxilla, you can notice that they are way out of alignment compared to the alignment of the spine. And if you look at the area of the airway, you'll see that there is asymmetry in that airway. Again, we don't want to confuse patient positioning with a pathologic entity, because anytime you see asymmetric airway, you have to anticipate that there is a space occupying lesion in the area. So in conclusion, we have to remember that lots of things have to go into preparing for the scan before you push that button, because we may end up with a diminished image quality if we rush that. So number one, think about the purpose for the scan. How much do I need to see, which is field of view? How well do I need to see it, which is resolution? Patient positioning, so that we can get that patient positioned so that the area of interest is as close to the middle of the scan as is possible. And realize, of course, that the majority of these scan killers can be avoided. Patient positioning, if you take your time positioning your patient, you're always going to get a better scan. Patient motion, remember not to use the gantry as a patient stabilizer. If you have a patient who's a little unsteady on their feet, you may want to put them in a chair so that they don't put additional weight on the gantry. And we want to get rid of any removable metal that we can. So in conclusion, many of these scan killers can be minimized if we can't avoid them completely. And our goal, again, is to create the best image with the lowest amount of exposure. Thank you.